session, Dr. Samantha Bendel demonstrates how to do a musculoskeletal assessment.
And then we're going to have a chat about
This involves an assessment of all 6 joints: the shoulder, elbow, wrist, hip, knee and ankle. The assessment of each joint follows the same process of look, move, feel. You inspect the joint, then move the joint, and finally feel the joint. But first, as in all physical assessments, you start by taking a relevant patient history with a focus on the problem joint. Find out what they were doing when the incident occurred, if they're in pain, and if they've taken anything for it. Find out about the history of the complaint and how they've dealt with it in the past. Ask about their current health status, including any pre-existing conditions and current medications. Before conducting the musculoskeletal assessment, Sam explains to Joe the importance of knowing your anatomy, comparing limbs and testing for reproducible pain.
You really need to know your anatomy when you're examining any joint, because if you don't know what you're looking at, then you don't know what's likely to be injured, you don't know where you're pressing, so that's really important. The other great thing about our bodies is we have 2 limbs, so you've always got something to compare it with. So always make sure that when you're examining one limb, have a look at the other side and see if it's the same. Okay? Okay. The third take-home point is to realise that any musculoskeletal pain is always mechanical pain. So that if you can't actually reproduce the pain, and if the patient's presented, for example, with shoulder pain, and you've gone through your whole shoulder exam and you can't reproduce that patient's pain, then you've got to think it's got to be coming from somewhere else. So remember, it's mechanical pain. If you can't reproduce it, it's unlikely to be mechanical pain, and you need to look somewhere else, for example, the heart or the neck. Okay. So, starting off with the look, what are we looking for?
From the back, look for symmetry, bony abnormalities, winging of the scapula, position of the shoulder and shoulder height, scars, redness and swelling. Make sure you also look from the side and the front, remembering to compare one side to the other. After you look, you ask the patient to move.
Abduct your arms up into there.
This is abduction, away from the midline of the body.
All the way up, that's great. And then adduction back down towards midline. Fabulous. And
look for reduction in movement and any differences in movement from one shoulder to the other. Also, while moving the shoulder, look for any indication of pain. A common shoulder complaint involves the rotator cuff.
If you're assessing someone's range of movement and you ask them to do abduct, and on one side they hitch their shoulder, and before they bring it all the way up, that should start you thinking that the patient may have rotator cuff pathology.
Okay.
Does that make sense?
Yes.
And what we're looking to do here is we're aiming to look for bony tenderness. So by feeling along
bony tenderness is increased sensitivity over the bony prominences. First, feel the medial border of the scapula by pressing firmly with 2 fingers. Walk your fingers along the ridge, observing for pain and feeling for any abnormalities.
Feels good. Now you can walk your fingers along. This is the spine of the scapula. Yep. Can you feel that? You can feel how it's a prominent ridge. That's good. Now come around the corner. That's it, right onto the tip of the shoulder there. That's right. That's the acromion
so
there. This is the acromion just here. This flat part here.
Okay.
Exactly. Well done.
Right.
Okay, and as you can see, it forms the most lateral tip of the shoulder here. Okay?
Yep.
So, and I'm going to turn Susan around again now, if that's okay. And then just walk your fingers along the clavicle here, again looking for any bony tenderness. Good. And when you get to the sternoclavicular joint here, you want to give that a bit of a press, because it's important to know that that's structurally intact, okay, and that's not giving you any pain. Sometimes pain from here can refer out to the tip of the shoulder, so it's important to give that a decent press.
So if you felt that, they would get pain?
They may get pain either here or there. Yeah, exactly. So it's important that you give it a press and make sure it's intact. Okay. Then come back along the clavicle. And the reason I teach this way, come all the way back, is so that you always know where you are, because you can always find the clavicle on any patient.
Yep.
Okay. And then come to the lateral tip. See, this is the lateral tip here of the acromion. If you walk your fingers off the lateral tip there, you can feel just a divot. I'll bet you might get Susan to turn around so you can feel that a little bit easier. Can you feel that? That's it? Perfect. Okay, that's a sulcus between the acromion and the head of the humerus. Okay. Right. So walk your fingers down onto the head of the humerus, and you'll feel it goes firm again where the bone is. Can you feel that?
Yep.
Yep. Good. And you just ask Susan to bend her elbow and internally and externally rotate a shoulder, you can feel that bony lump come underneath your fingers.
Yes.
Can you feel that?
Yep.
Okay. And to complete the bony tenderness, we're just going to come down the shaft of the humerus and make sure we haven't missed any occult fractures down the head of the shaft of the humerus here.
Any pain down?
No?
All right.
Okay.
As Sam has identified some potential rotator cuff pathology, she conducts a special test.
Susan, I'm just going to borrow your shoulder for a second, and all we're looking for is pain here. Okay, so we're going to abduct the shoulder, and what I'm going to do now is just internally rotate here. Okay, and if you tell me if you have any pain there.
A bit, yeah.
Bit there? Okay. And so it's likely that Susan probably has got some subacromial bursitis there, and obviously we would compare it to the other side. Okay.
First, you look for swelling, symmetry and scars and any other abnormalities. As well, there is a special test for a fusion of the elbow joint.
So what we're doing is we'll put 2 fingers behind either side of the acromion, the olecranon and acromion, either side of the olecranon, and we're going squash, 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 and aiming to see whether there's any fluid that moves underneath my fingertips. Okay.
For the move part of the assessment, you will need 2 pens.
So, Susan, I'll get you just to put both hands out like this, so it's anatomical position, okay? Elbow slightly flexed, patient nice and comfortable, and just close your fists, okay? And with the reason that we do this with a pen on each side is to see if there's any difference, okay?
Okay.
When we're describing range of movement, we used to use a goniometer and all sorts of horrible things to make our lives difficult. Now we just say it's either normal, range is normal, mildly reduced, or moderately reduced, or severely reduced. Okay, and again comparing to the other side. So, all right. So, can I get you to turn both hands over for me? And you can see both pens move equally, so that they're the same on the other side, and then supinate. So, turn one more time, if that's right. Pronation, that's good, and supination. All right, and then we'll get you to flex all the way up. Perfect, and extend all the way out. Excellent, well done, thank you, and just relax.
If you notice a restriction of movement, you need to determine whether it is caused by a fixed deformity. You do this by assisting the patient to perform the movement.
So if Susan was sitting there with one elbow, say, slightly flexed compared to the other side, and that was her resting position, we might think, well, maybe she has got a fixed flexion deformity there. And then we get her to do a range of movement, and we go all the way up. That's good, that's it, perfect, and all the way out. And we'll say this one stops there, and then I try and do a little bit more, I can't get it any further, then I think, okay, well, she looks like she's got a fixed flexion deformity, her resting position is this way, I can't get it any further than that, that's what she has. And so someone who's been, who's had a stroke, for example, or someone who's been in that position for a long period of time may get a contracture which might result in a fixed flexion deformity, so that's important.
Next, you feel the elbow. To ensure you don't miss anything while you palpate, start just below the armpit.
And come down, just palpating the humerus, make sure I haven't missed a supracondylar fracture or something else. Good, okay.
No pain in your upper arm?
There isn't.
Okay, good. So now you're going to put one finger or your thumb on each of the bony prominences we talked about. Okay. So first of all, find the medial epicondyle, because you can find that on everybody. Okay.
Just here.
Good. You can see that I've marked that with a great big purple circle.
Oh, yes.
Yep, perfect. Okay, all right. So do it just with the elbows just slightly bent. That's good. Okay, so is there any pain?
Any pain there?
There isn't, no pain.
No? Okay, good. Now find you can let go of that one because you don't want to be pressing on 2 things at the same time, otherwise the patient gets confused. Try it now, go for the lateral epicondyle.
So that's the lateral one?
Yep, that's perfect. Good, and I've marked that with a good purple circle too. Perfect, okay. Now we're going to go and feel the olecranon, which you'll feel at the back there.
There we are, right the back.
And if you're in any doubt, you can get the patient to ask Susan to bend her elbow all the way up so you can actually see it. Good, excellent. Okay, and again, I like to use it to
use a bit of force and make sure it's not.
Make sure it's not sore, and then you can come down the subcutaneous border of the ulna. You don't have to go all the way down, but the radial head is sometimes a bit tricky to find on people, so you can practice finding it on yourself. Is the easiest way. But I'll just show you a couple of tricks. So the first one is you find the lateral epicondyle, so on the lateral side with your thumb, okay? And then you come down about 1.5 centimetres to 2 centimetres and slightly medially, and then you just rotate.
And you can find...
Exactly, you can feel it rotating underneath your thumb. So if you put your thumb where I've marked on Susan, and
just going to rotate your arm, Susan.
Obviously you need to make sure they don't have a wrist injury before you do this.
And there, yeah, you can feel the...
Can you feel that rotate underneath you? Yep, excellent. Okay, so that's the radial head.
Down,
and then there are some nerves and a lot of your forearm extensors on that side. So the simpler way is just to make sure you just give a bit of the ulnar and radius a bit of a squeeze to make sure that there's no bony tenderness.
Okay.
All right.
When looking at the wrist and hand, again look for redness, scars, swelling with particular attention to any muscle wastage.
Particularly of the thenar and the hypothenar eminence. Okay, that's really important because that's looks at your median ulnar nerve function. Okay. We want to look at flexion and extension in the wrist joints. So I'll get you just to turn your hands over if that's okay. And we're going to get Susan to extend her wrist as much as possible. Good, that's it. And then we'll flex on the other side, so you can have your hands off the bed, that's fine. But as long as it's the same on both sides. Some people do ulnar deviation and radial deviation, but that's probably less clinically useful. All right, so that's the wrist joint function. Now in terms of the movements of the hand, what we need to do is make sure that the extensor tendons, which come down on this dorsal surface of the forearm and insert into the both the PIP joints, which are these ones here, and the DIP joints, and they extend the fingers all the way up, are intact. And we also want to know about the flexors. Okay, so we'll talk about the extensors first. So we want to make sure each of these fingers is adequately extended.
And to the same degree?
Yes, exactly.
Can you have one finger injured only?
Well, if you have one finger that's not playing nicely, you know that perhaps that
so they're all separate?
Exactly, they're all separate tendons. Yeah, well done. Okay, all right, and then we turn your hand over. Thank you. Now, the flexor tendons here are a little bit more tricky. The superficial flexor tendons, there is a superficial and a deep one that runs through your forearm. The superficial ones end at the PIP joints here, and the deep flexors end at the DIP joints here. So you need to make sure both of those are intact. So a quick way to do that is just say, can you bend the top joints of your fingers? Perfect. Now make a fist. Okay. And then you've seen
that they're all working.
Exactly. Deep flexors are okay, superficial flexors are okay, and they can make a fist. Perfect. Okay.
Next, you feel. Always start above the joint.
So I'd probably come down here, go to the radial side first because that's usually one that's injured.
Okay.
Right. Feel the radial styloid here, come across the distal radius along here and onto the ulnar styloid. Okay, that's just an order of what's most likely to be injured.
Okay.
As you look at the hip, it's important that you look for any evidence of surgery. If the patient has had a hip replacement, you should never rotate the hip.
That's right. We don't want to put her in this position, do we? Because we might dislocate the hip. Exactly. Well done. Okay. And the other things we're looking for, any redness around there, any swelling. Now, an effusion can be very difficult to pick in the hip joint, and usually you can't see it, and you can only see it on ultrasound or other forms of imaging because it's a very deep structure. So we probably won't see that on that side. Any deformity, as we said before, particularly if the leg is shortened and externally rotated, we've got to think of a neck or femur fracture.
Okay.
Can I get you to flex your hip? So bend your leg all the way up as far as you possibly can. And you will not see this very often.
Wow, very
That's
flexible.
amazing, isn't it? So that's flexion, and then we're going to put your leg all the way back on the pillow if that's okay, and that's extension.
Right.
Okay, and going back to the bed is fine. We can go out the back if we wanted to, but full extension is fine. Okay, good. So that's flexion and extension. The next thing we're going to do is abduction away from the midline. So Susan can either do this herself, but some patients you may have to help. So I'm just going to demonstrate if that's okay. I'm just going to put my hand on the other side of the pelvis, and we're going to take Susan's leg as far as it will go all the way out to the side. And remember, this is something you don't want to do in a patient that's had a hip replacement.
Yes.
Okay, and adduction back to the midline. Now we're going to do internal and external rotation, and these are very important because they give a better idea of hip function and how stiff a patient's hips really are. So if you bend the knee up to 90 degrees here, and we're going to internally rotate the hip to start off with. Okay, now I know this looks like we're externally rotating, but we're not. We're internally rotating the hip joint, but the foot goes outwards. Exactly. So remember, it's the opposite to what you think it would be. Okay, internal rotation, foot is outwards. External rotation, foot is inwards. Okay, that's internal rotation, external rotation. And the last thing we're going to do is the hip quadrant position. Now this is quite a useful test if you think the patient has hip joint pathology and you haven't sort of been able to bring it out, but this is the point in which the femoral head has the most contact with the acetabulum and the synovium. So if there's any irritation of the synovium in particular, that's the lining around the joint, then you'll be able to bring it out in this position. Okay? So you want to flex the knee up, the hip up as far as possible. I want to internally rotate, meaning the foot goes outwards, and then I'm going to press directly down. And I'm going to ask Susan if she has any pain in her hip. I'm keeping an eye on her face to make sure she's not wincing. Okay? All right, and then we can go back to normal. Okay? In terms of feel in the hip joint, really it's a very direct palpation. So you want to feel over the groin area, and then the other place is the greater trochanter, which, as we said, is the knobbly part on the outside here. And then just come down the shaft of the femur to make sure that there are no femoral fractures that you've missed. Okay.
To begin the knee assessment, ask the patient to stand up. Look for symmetry in the knees.
We can see Susan's knees are symmetrical. We can see that both patella are pointing forward.
Also look for any abnormalities in the straightness of the legs.
Sometimes older people, particularly people who've had vitamin D deficiency or things like Paget's disease, might present with a varus deformity where they have the bow legs. Exactly, something along those lines. All right. Otherwise, you can have knock knees, which is a valgus deformity, along those lines. So you just want to note those.
Ask the patient to walk around. Note any abnormalities in gait.
Does she have an antalgic gait? So she's putting weight on one particular foot and leaving weight off the other, a limping type gait, anything else that might be contributing to the source of her knee pain. All right.
Continue the look part of the knee assessment with the patient lying down. Look for symmetry, swelling, redness, scars and especially muscle wastage, which could indicate a history of knee pathology.
Now, the last thing we're going to do, look-wise, before we move on, is looking for an effusion. And we do this using a swipe test. Now, there's a suprapatellar bursa, which is, remember we said the bursas are fluid-filled sacs? Yep. Most of the time they don't communicate with other things, but in the knee joint, the suprapatellar bursa, which is here, communicates with the rest of the knee joint, which is great for us because it gives us a place to put all the fluid in the knee joint and swipe it back into the knee joint so we can see it. Okay? So this is like driving a race car, basically. If Susan's got fluid in her joint, what we will lose, first of all, is this nice divot here. Can you see that there's a nice hollow in her knee here and the same on this side? And the first thing that we'll notice here is a fullness in this area here if she's got any fluid there. So what we're aiming to do is swipe all the fluid in the joint up into this suprapatellar pouch here and then run a hand down the other side and watch in this area where the hollow is to see if there's a pop, if there's a pop out. So hand over hand over hand over hand over hand up here, and then take your hand away, swipe down the other side, and I'm looking here to see if there's any fluid in Susan's knee. Okay? Hand over hand over hand over hand over hand. Swipe down, looking here to see if there's any popping out of that little hollow there. Okay? If there's a very tense effusion, you may not see the movement there because it's so tense, but what you'll notice is this up here looks much, much fuller and much tenser compared to the other side. So that's why it's important to expose both knees and have a look at both knees. Does that make sense?
Yes. Susan, could I get you to bend your knee up onto the bed?
That's it.
So how do we
want to go all the way as far as you can
far back as you can.
Good, perfect. That's it.
Yep. So full range of movement in the knee and then back down again.
Exactly, all the way
full
back
extension.
Down. Perfect, well done. Okay, and sometimes if you're worried, you can make sure that they can just slightly hyperextend the knee. The next thing that's useful to do at this point in time, just because it's convenient more than anything else, is to ask Susan just to lift her leg straight off the bed. And what's that telling us?
That all of these ligaments are intact?
We're showing that the quadriceps tendon and the patella is all working fine. The whole extensor mechanism is intact, and you can drop your leg down now. Okay, she won't be able to do that, but if her patella's fractured or if she's got some problem that's interrupted this extensor mechanism. Okay, exactly. Okay.
Palpate along the medial joint line.
Okay, well done. So medial joint line, follow it all the way around, go up onto the bone if it's sore, down onto the bone if it's sore, and then we'll have a look at the medial collateral ligament and the meniscus separately. But you can palpate along the length of the medial collateral ligament if there's any pain in that area and see if it's sore there. Okay. Then we do the same on the lateral side. Bring your thumb up, come on around and do exactly the same thing down the lateral joint line, making sure you stay in the joint line. If she's sore, up onto the bone, down onto the bone, and you can palpate along the ligament there.
Okay.
Good. Okay. Palpate along the head of the fibula here. Then we want to go all the way around the patella. Now we know that patella's intact because we've already made her lift her leg off the bed. Good. All right, and we're just looking for tenderness here, and then coming down onto the tibial tuberosity here.
Yes.
Okay, so they're the bony parts, and then we want to come down the same thing as we do before, and we do the femur, and then come down to the tib and fib as well.
Okay.
Does that make sense?
Yes.
Okay. Do you want to have a quick feel of the medial joint line here?
So find that divot in there.
Good. Okay, and then come around.
So here's where the two bones meet.
Yes. Can you feel the space between the two bones?
Yes.
Yep. Good. Excellent.
So that way up.
Onto the femur. And down onto the tibia. Good. Excellent.
Next, you examine the ligaments.
Okay. So, Susan, what I'm going to do now is just test your ligaments here. What I want you to do is just relax just gently into my hand here. So you want the knee to be not entirely straight. You want it to be about sort of 10-20 degrees of flexion. And I'm supporting the ankle here, and I've got the heel of my hand over the lateral joint line here. And then what I'm doing is I'm using my shoulder to give me some power because I'm a 2-pound weakling, and I'm pushing that way, okay, to apply stress to this ligament here. Good. Okay, so I'll show you what I'm doing. So I'm pulling back with my right hand and pushing with my left hand, like so. Okay. The important thing, the trick for the young players here is rotating the ankle like this. You need to make sure everything stays straight and in the same line. So just pushing straight outwards. And I'm saying to Susan, is that sore? And I'm making sure I can feel a nice end point there. It shouldn't be sore in a normal person.
Okay.
All right, so same thing on the lateral side, just swap your hands over. All right, so again, Susan, I'm just going to swap my hands over here. Okay, and I'm pushing towards me.
To stretch this.
To stretch that, exactly, well done. Okay, so that's the medial and the lateral collateral ligaments, making sure you don't twist the ankle and keep everything nice and straight.
Okay.
Okay, good.
Next, assess the anterior cruciate ligament, or ACL.
So this is called a modified Lockman's test, and what we do, this is a cheat's way of doing it, and the reason I teach it this way is because anybody can do it on any size knee. Okay, I've got small hands, and at a big rugby player it's quite tricky, but this is a tricky cheat's way of doing it. Okay, so I'm going to put my knee up on the bed, and Susan, I'm just going to get you to relax over my knee if that's okay. All right, so I'm going to apply pressure down here. So again, I'm anchoring the femur, hand underneath here, and I'm pulling straight up to the ceiling. Okay, pulling straight up. And you can see here it's solid as a rock. Do you want to have a quick feel?
If the joint feels like chewing gum with no definite endpoint, this may indicate that the anterior cruciate ligament, or ACL, is ruptured.
Good.
So anchor this one and pull up there.
That's good. So turn your hand over
that
this
way.
way, come right underneath and pull just straight up to the ceiling. Good. Can you feel that that's nice and solid? Perfect. That's a modified Lockman's test. That's really well done.
Next, you test the posterior cruciate ligament. You test this ligament using the anterior draw test with the patient lying down and their knees drawn up.
So what you do is you just say to the patient, Susan, I'm going to sit on your foot for a moment. I hope that's okay. All right. And then I'm going to put 2 fingers behind here. I'm going to relax the hamstrings with my 4 fingers, put my thumbs either side of the tibial tuberosity, and I'm going to pull forward as far as I can and push backwards as far as I can. And you can see that that tibia is not going any further back, is it?
Yep.
So, and if she had a posterior tear, it'll go further back than the other side, okay?
Right.
Again, I would compare the same. Go around the other side, compare it to the other side, okay?
Okay.
Does that make sense?
Yes.
Good, okay, so that's anterior and posterior cruciate ligaments. The last structure we need to have a look at in the knee joint are the menisci, which are, remember, those tough fibrocartilaginous structures?
Between the bones.
Exactly, between the bones. And then, how did we injure them?
With the
Compression and rotation. That's good. So that's exactly how we test them. Okay. So this is a modified McMurray's test. You'll see different versions of this done, but basically what we want to do is use this hand and the heel of the, put your hand around her heel and you're applying compression here. Now the obvious caveat to this is you need to make sure they don't have a foot or an ankle injury. So I need to say to Susan, is your ankle, your foot sore? Is it okay if I do this? Fantastic. So I'm going to apply compression here, and then I'm just going to rotate the leg here to see if there's any pain, which might indicate a meniscal tear. Okay. So I'm going to go medial meniscus, lateral meniscus. Okay, but they're really testing a bit of both. Okay. Good. So what are we looking for?
Any swelling or redness or previous scars at all?
Okay, and will you see swelling around the ankle joint?
Yes.
Yes, you will, exactly. Okay, and so you may see diffuse swelling in here, which means they've got fluid in the joint, but more commonly, particularly if they've had an inversion injury, you might see a swelling around here, which is around the anterior talofibular ligament, or the ATFL, okay? And that's the one that people most commonly injure when they invert their ankle. Okay, so we're going to ask Susan to dorsiflex her feet. So we're going to say, could you please pull your feet all the way up as hard as you can? And again, we're comparing to the other side, same as we did. Okay. And now we're going to get you to plantar-flex. So put your foot all the way down, point your toes. Perfect. Okay. And as you can see, it's the same on the other side. Yep. So we're going to ask Susan to invert her feet. So bring your soles of your feet together. That's good. Okay. Keeping your knees nice and still. So we're just going to move your ankles, move them in, and move them out. Okay, good. And I'll get you to do that yourself if that's okay. So that's it, and the other side. And the way I always remember is if I put a smiley face in the bottom of the feet, I'm going to bring them in. That's inversion, and then I'm going to bring them out, eversion. Okay, good. Okay. And you can see the movement's the same on both sides. So we'll start up to here, remembering we need to start proximally. So we're going to palpate the proximal hip fibula here, and we're just looking for pain, okay, for tenderness. Coming down here, you'll actually lose the bone in the perineal muscles here, but you'll rejoin it about 6 to 10 centimetres above the lateral malleolus. So coming back down onto the bone here, and again we're looking for bony tenderness, and in this area it's really important that you just use 2 fingers to be right on the bone itself, because if you go backwards then you'll hit the perineal muscles and you won't know where you are. Right. Okay. So coming down onto the lateral malleolus here, we need to stay inferiorly and posteriorly, because that's where the money is. There's a ligament that sits here, we talked about that, the ATFL. Yes. Yep. And that's tender on anyone who's had an inversion injury. So if we're palpating at the front here, start palpating that, they're going to be tender. We don't know if it's bone or whether it's ligament. Okay, good. So coming down inferiorly and posteriorly on the lateral malleolus. Then we want to come onto the medial side, because we know that those 2 things hold the ankle joint together, the medial and lateral malleolus. So I'm going to come down the medial side and staying in the same area. I'm going to stay posteriorly and inferiorly right on the bone. All right, good. The next thing I'm going to do is have a feel along the proximal tibia here. Now I've drawn the joint line on Susan here, but you can actually feel it quite easily. So that's why this position is so good, because they're nice and relaxed. Right. So I'm going to use my thumb, and I'm going to just press over the edge, and I can feel the inferior edge of the tibia here, and just see if there's any bony tenderness there. And that gives me a location point, so I can go, I know exactly where I am. This is on the model, this is what I'm feeling right here. Okay, beautiful. And this also allows me to feel if there's any swelling in the joint as well, because it'll feel a bit squidgy. Okay. Coming around here, this is the joint here between, where I've marked here, between the tibia and the fibula, and I'm just looking for any tenderness there. It's I may or may not feel any extra movement in there, probably not. Okay. Good. All right, the next spot I want to have a look at is the base of the 5th metatarsal. Do you know why that's important? If somebody inverts their foot, like so, what are the structures that might be damaged?
One of the ones that might break.
Exactly. Anything on the lateral side. So proximal fibula, lateral malleolus, base of 5th metatarsal. They're all the things that go when you have an inversion injury. So we need to have a look at that, and that forms part of the Ottawa ankle rules, which I'll refer you back to your manual to have a look at, if that's okay. So we just want to have a press, and you can feel here. Do you want to have a feel? It's to the bony prominence on the outside of the foot.
Oh, yep.
Yep. Excellent. You can always find that in everybody. Okay. So just to recap, we've done proximal fibula, lateral malleolus, medial malleolus, base of the 5th metatarsal. We've had a feel along the distal part of the tibia here. And now we're going to try and find the navicular, because why do we need to find that?
Is that what will break on the other side?
Exactly. So remember we talked how that's like the scaphoid in the hand. It doesn't have a particularly good blood supply, so we need to press on it to make sure it's not sore, to make sure it's not broken. Okay. All right. So going back to where we know we are, we can find the base of the tibia here. The next thing we're going to feel, and I'll get you to have a look at the model while I do this. Sorry. That's it. The next bone I'm going to come down onto is the talus. That's good. And the next bone, so then I'll find the joint line between the talus here and the navicular here, and the next bone I'm going to come onto is the navicular. This is called the end spot. It has a little tubercle like the scaphoid does. Remember we found that little knobbly lumpy thing? has another little knobbly lumpy thing which might be a little bit tender. Is that a bit tender there? Yeah. So it will be a little bit tender, but it shouldn't be really, really sore. Okay, and if it is really sore, you need to think that the patient might have a fracture there.
Okay.
All right, and then the same as we did in the wrist, we want to have just a general feel over the tarsal bones to make sure there's no obvious tenderness. Then we're going to just palpate all up the metatarsals. Again, being very directed as to where we're pressing to make sure we're actually on the bone, and the same thing in the phalanges, just to see if there's any tenderness there. Okay.
Okay.
The last thing we're going to do, and this is again looking for that Liz Frank fracture that we talked about before. One of the things that you want to have a look for, particularly if anyone's got swelling here through the midfoot, we want to see if there's any tenderness there. So we're going to just gently twist through the midfoot there. Normal patient, that shouldn't be sore, but it will be very sore if they have a Liz Frank fracture, so you want to do it carefully. The last thing I want to have a look at is the ligaments. Now there are two major ligaments that you need to worry about. Well, not worry about, that's probably a bit strong, but we need to know that they're there. The first one is the deltoid ligament, which runs here. That's on the medial side. It sits in there. So what might be broken if I do this?
That ligament.
Perfect, well done. Okay, so again, same thing. Just be aware that it might be that's a structure that might be injured. On the lateral side, there's a complex of 4 ligaments, just generally referred to as the lateral ligament complex. But the most commonly injured one is the one that goes from the at the anterior part of the fibula here down onto the talus here, and it's called the anterior talofibular ligament, or ATFL. And this is the one that's most commonly broken or injured when you have an inversion injury, and that's when the patient will present with a big swelling over this area here.
Right.
Okay. So how do we test the ligaments? How do we test the deltoid ligament, for example?
By stretching them.
Exactly, same as we did in the knee joint. So again, we're just going to give a quick stretch to make sure that it's intact. Okay, so all we have to do here is evert the ankle here. And we're looking for pain and any excess movement. And the same thing we'll do on the other side. Okay, very simple test. The other thing you can do looking for disruption of this complex here and for the lateral ligament complex is called the anterior draw test. So again, that's why this position is so useful. Anchor the bottom of the tibia here and just gently pull forward. And again, you just want to see the degree of movement, and then you want to compare it to the other side. And you can see here that they're exactly the same.
As you've seen here, the musculoskeletal assessment involves a process of look, move, feel of all 6 joints. With lots of practice, you will develop your skills and confidence in this form of assessment.